afternoon, everyone. I hope everyone's doing well. I am Sarah Ali, and I'm a first-year fellow at University of Miami. Thank you, Dr. Jane, for giving me the opportunity to present at today's Journal Club. And I would also like to thank the mentors, Dr. Bergman, Dr. Carlo, and Dr. Wolf for being here. And please feel free to interject during my presentation. I would love for all of us to have a good discussion. So like Dr. Wolf mentioned, the article that I would be presenting today is titled Immediate Kangaroo Mother Care and Survival of Infants with Low Birth Weight. This study was conducted by the WHO KMC study group and was published in the New England Journal of Medicine in May 2021. So I wanted to first give some background regarding kangaroo mother care. So WHO defines kangaroo mother care as continuous skin-to-skin contact of the infant with the chest of the mother or another caregiver when it's not possible for the mother to do so, along with feeding exclusively with breast milk. The kangaroo mother care is one of the low-cost interventions that is known to have a lot of benefits, including decreasing mortality, fewer rates of infection, and higher rates of exclusive breastfeeding and better weight gain in infants as well. It has been mostly studied in low and middle income countries. There was a Cochrane neonatal review in 2016 that reviewed 21 randomized controlled trials on kangaroo mother care, and it included 3,042 infants. 19 studies out of those 21 evaluated kangaroo mother care in low birth weight infants after the babies were stabilized. One review was in low birth weight infants right before stabilization, and there was one which compared early onset kangaroo mother care with late onset kangaroo mother care in relatively stable low birth weight infants. And there were 16 studies that evaluated intermittent kangaroo mother care, and there were 5 studies that evaluated continuous kangaroo mother care. So the review showed that compared with conventional neonatal care, kangaroo mother care was found to reduce mortality at discharge or at 40 to 41 weeks post-menstrual age, and it also decreased the rates of infection and rate of hypothermia. Moreover, with kangaroo mother care, there were also noticed increased weight, length, and head circumference gain, and rates of breastfeeding at discharge. They also tried to evaluate the neurodevelopmental outcomes, but they did not see any differences at 12 months corrected age. So currently, according to the WHO guidelines, they recommend intermittent kangaroo mother care when the infant's condition begins to stabilize, and then continuous kangaroo mother care when the infant's condition has stabilized. What clinical stabilization really means is that the baby does not have any tachypnea, the baby is not on any CPAP, baby is able to maintain saturations above 90% on room air, they're able to maintain a normal temperature, and there's no need for any IV fluids. There's still a knowledge gap regarding the effect of initiating kangaroo mother care soon after birth and before the stabilization with respect to mortality in infants with low birth weight. So in this study, what the researchers aimed to do was to evaluate the safety and efficacy of continuous kangaroo mother care initiated immediately after birth in infants with a birth weight between 1 kilo to 1.799 kilograms.
So Dr. Bergman, a question for you. Since you have been involved, you spent your whole career on this kangaroo mother care or skin-to-skin contact. We usually discuss articles in the Journal Club, which, had some basic science data, which led into some preclinical studies and stuff. So what was your motivation when you started it? What was your understanding of the topic, which led to this intervention, which has such a profound effect on neonatal mortality?
Thank you. So Sarah, what you presented is the correct context for presenting the study. Good, thank you. It's not actually the current recommendations of the WHO, just to flag that.
Yes, so after the study, they changed the recommendation, yes.
I hope you'll come to that later, but I'm jumping the gun in that case. So indeed, thank you. Viral, your question?
Yeah, so can you walk us through your background of how you came to design Kangaroo Mother Care and what was your motivation behind spending your whole career on it?
Wally and some of you looked funny when you heard that I did a PhD on scorpion stings. That is serendipitous. Scorpions. So the answer to, well, this is a long, I must be very brief because Sarah's got to finish a lot of stuff. So 1988, I started working in a very remote mission hospital. And the first few months, we introduced the skin-to-skin contact based on 5 known publications in 1987. There wasn't more than 5 publications that we could find. And they weren't dogmatic about many things. So we started the skin-to-skin on our newborn babies immediately after birth because we simply didn't have incubators. Very simple. And those articles didn't forbid us. The subsequent articles say, "Ooh, the baby must be stable." 1988, my midwife colleague, whose name you introduced, Agneta, trained neonatology in Lund, very high level, sophisticated. I learned neonatology in Cape Town, where a lot of technology, including CPAP and many other things, were invented. We both observed a different species of newborn when it was in skin-to-skin contact. And that was just a quick observation that went on for 6 years. But in those 6 years, I actually spent most of my efforts mapping scorpionism and scorpion kills with an autonomic nervous system venom. What it did, and my interpretation was that I had 2 deadly scorpions, one parasympathetic and one sympathetic. They had different mechanism of death. This was contentious, and I had to read Goodman and Gilman, a third of Goodman and Gilman, to understand the autonomic nervous system. Yes, long story here. This grounding of the autonomic nervous system is actually how now I have followed through a understanding of a science that's applicable to neonates. So how have I come upon this journey? That's a longer story than Sarah deserves to hear. I think what I can say then is that we published a paper, and then I spent 10 years publishing the next paper, which was in 2004, a randomized control trial. And it's very clear and it's very obvious, but it was totally rejected. It took another 10 years to persuade with great difficulty. Actually, it took 6-8 years. But that was the background to sticking with us. Eventually, a program officer who you will know, Janet Patterson, eventually heard what I was saying and took this forward. So she's still with your AAP, and she was able to persuade the Gates Foundation to fund the study with the World Health Organization.
I think that is really impressive to hear. And even for our trainees, even if we have come from different backgrounds and training, you can always apply that training to design such a great trial to reduce mortality. So no training is wasted. Great to hear, Dr. Bergman, your insight. Sarah, you can continue.
Perfect. Thank you so much, Dr. Bergman. So the research question that the investigators presented was, so the population, they looked at infants born with birth weight between 1 kilograms to 1.799 kilograms. The intervention was initiation of kangaroo mother care immediately after birth. The control or comparison was conventional care in the incubator or warmer until the baby's condition stabilized, and then intermittent kangaroo mother care thereafter. The outcomes that they looked at was mortality in the time period of the neonatal period, which is the first 28 days after birth, and in the first 72 hours after birth. So talking about the methods, so this was, like we discussed, was a multi-centered randomized control trial. There were 5 tertiary level hospitals situated in low and middle income countries, located in Ghana, India, Malawi, Nigeria, and Tanzania. So the inclusion criteria was infants who were born alive in the participating hospitals with a birth weight from 1 kilograms to less than 1.8 kilograms, regardless of their gestational age. And the mother-infant dyad was eligible even if the infants were twins or were born by C-section, or if the mother experienced some complications during labor and delivery that were expected to be resolved within 3 days. The exclusion criteria included if the mom was younger than 15 years of age, if the mother was unable or unwilling to provide consent, if the mother gave birth to 3 or more infants in this pregnancy, if the mother was sick and was unable to do kangaroo mother care within the first 3 days after birth, if the baby was unable to breathe spontaneously within an hour of birth, if the baby had a congenital malformation that interfered with the intervention, or if the intervention interfered with the required care for the congenital malformation, if the mother resided outside the study area. So the study area was a predefined area that was made, discussed or decided to make the 28-day follow-up home visit more feasible. So if the mothers resided outside of that defined study area, then they were excluded. And if for any reason the mother-infant pair could not be enrolled within the first 2 hours of the birth of the infant. So this study was approved by the Ethics Review Committee at WHO and then at each study site. There were 3 independent teams that were trained and were responsible to screen and to enroll and measure outcomes at each site. All the pregnant women were pre-screened to identify women at high risk to deliver a low birth weight infant. So there was a pre-screening form which included variables like if mom had preeclampsia, if the baby was IUGR, if mom had history of anemia, anything that would pose a higher risk for the baby to be of a low birth weight. So all the pregnant women were pre-screened. All the infants who were born, they were weighed and then they were screened for eligibility. Randomization was performed using computer-generated blocks. The blocks were variable in size and were stratified according to the site and weight. The assignments, they were
So, Wally, a question for you. I think Sarah's connection is a little low for it. So, Wally, you've been designing trials for so long in low middle income countries. Can you just give us some insight how difficult it is to do that, how different it is compared to doing trials in the US, and how do you get buy-in and all this great follow-up for all these infants?
Yeah, so this is excellent that they had 3 trained and independent teams. So it is extremely important to separate the intervention team and the outcome measurement or outcome assessment team. So I think for the clinicians in the US and the researchers, that's an important lesson also, because that's essential that the intervention is done by a team that is different to the outcome measurement team, and that there's somewhat of a masking of the intervention. So this is an excellent point. And you asked, Viral, is it difficult? Yeah, it's difficult because you have to have independent teams. So you have 5 sites, now you have to have 15 teams.
Okay. So is it hard to get buy-in for you in the studies in low middle income countries?
No, actually, the consent rates from the parents, for example, are very high. The support of the healthcare system frequently. I work in where our study was done in 96 communities, if you can imagine. So there's a lot of support from the community, a lot of interest in participating in these trials with high consent rates.
Yeah. Dr. Bergman, question for you. How difficult was it for you to put all this team together for the study?
think once we got past the point of identifying the sites, we did a feasibility study that took 9 months, and that led to a proposal, a protocol. That in turn got funded, and the sites got pruned down to those who could do this. So we did a lot of work behind there. One of the difficulties that I would have got rid of one site in the retrospectoscope. It must have very close collaboration between obstetrics and gynecology and neonatology. Very close, much closer than you imagine, because this becomes weaved together. There needs to be physical space. These are two big pieces that were difficult and that had to be solved by commitment. I will say that, let me say, Rajiv Bahl was the director from the WHO, and he said this is the highest risk study he's ever conducted, and he ever put in the energy to make it happen. So a lot of the real politics behind the scenes actually required his experience, and Wally details these practical pieces. Rajiv Bahl personally came and taught all of these steps at each site to the every single person who was involved. So I learned a lot just from that, a huge amount. Yes, it was an intensive exercise in applying research methodology. And Dr. Bahl put together a team from his office that focused on this also. What was perhaps not emphasized in the article here to add here is that we were also a consultant support team from the Karolinska Institute, 3 neonatologists, constantly monitoring that the standard of care was the same to both groups and that it was the highest possible to attain. Myself, broadly responsible for the method, and my wife, who actually taught the specific technique intervention, the same as she taught in Stockholm and Norway, she taught in these 5 countries. So that was a very intensive and huge investment. Viral, I hope I'm answering your question. All of these things were critical. I think that this worked and was successful.
Certainly, it took a whole big team to get this to the intervention, which Sarah is going to present to us. Sarah, you can proceed.
Yes. So obviously the nature of the intervention prevented blinding, but the outcome assessment was conducted by an independent team whose members were not involved in intervention delivery. So the intervention was kangaroo mother care, defined as continuous skin-to-skin contact with the mother or her surrogate, aiming for at least 20 hours per day immediately after birth. So this intervention was executed by 3 principles. Number 1 was promotion and support for continuous skin-to-skin contact initiated as soon as possible after birth, healthcare for mother and infant provided without separation, and promotion and support for early and exclusive breastfeeding. So to implement this intervention, obviously there were some changes that had to be made to the existing structure. Some new or modified NICUs were created, and they were termed as mother NICUs. And that included the beds of the mother, some reclining chairs, so that the mother and the baby could stay together. So all the equipment, staff, and the care provision in the mother NICUs remained exactly the same as the control NICUs. At 2 out of these 5 sites, they had to create a completely new mother NICU in a nearby location, and the existing NICUs were retained as the control NICUs. And at 3 other sites, the modifications were made to convert half the existing NICU to mother NICUs, and the other half served as the control NICUs. The infants receiving kangaroo mother care were secured firmly to the mother's chest with the binder that ensured a patent airway. All the care of the mother and the infant was provided while skin-to-skin contact was maintained, and all the interruptions that happened during the kangaroo mother care were documented. After that, the infants who were assigned to the control group were transferred to the control NICUs without their mother in accordance with the standard practice. And mothers provided expressed breast milk and participated in brief sessions of kangaroo care while at least the baby was, at least 24 hours old. And then in both the groups, once the infants were clinically stable, they were then transferred to the kangaroo mother care ward, where continuous kangaroo care was provided to all the infants until they got discharged. So the primary outcomes that the study looked at was neonatal deaths between enrollment to 72 hours of age, and the neonatal deaths between enrollment to 28 days of age. The second outcomes which were observed were hypothermia, which is any auxiliary temperature less than 36 degrees Celsius, any event of hypoglycemia, which is any blood glucose less than 45 milligrams per deciliter, suspected sepsis. Suspected sepsis was defined as clinical deterioration after initial improvement of the baby. So that meant if the baby had more respiratory distress after initial improvement, or if baby developed new onset fever or a hypothermia. So that was defined as suspected sepsis. Time to clinical discharge, exclusive breastfeeding at the end of the neonatal period, maternal satisfaction with care, which was obtained via a questionnaire, and maternal depression that was based on the PHQ-9 score.
Dr. Bergman,
So-
can you share some insight with us in terms of how you decided on these specific primary and secondary outcomes and any unexpected challenges that came up with measuring any of these?
Perhaps, Sarah, you could go back the slide. The primary outcome, I had, so I've worked in third world, low income countries, and my own experience was that the mortality I would see in the first 3 days. So I personally had pushed for the 3-day. This is also the period when most required to stabilize. So these 3 days are unstable babies. Actually, these were tertiary hospitals. They had CPAP. We taught them how to do the CPAP. Actually, yes, there was a difference at the death rate at 3 days, but really the big factor came out at 28 days. So the 72-hour one, in the context of these tertiary hospitals, did not reach significance with the sample size that called the stopping rule. Beyond that, to do a rigorous randomized control trial and 5 sites, you can't be too ambitious. Perhaps the next slide, Sarah. Yeah, wouldn't it have been nice to get epigenetics and microbiota but no, we have to nail the primary outcome, and then we mustn't let secondary outcomes obscure what is our primary outcome. But these are also practical, basic things. So this list is pruned, partly also by the contextual realities. One of the outcomes that isn't here, for example, would be hypoglycemia. It is reported, but that would have, including it, would have mean providing the whole system for measuring it in 3 hospitals that didn't have it at all. So there's a scope creep. It does not have here delayed cord clamping. That would have been a co-intervention. It would have been, so it was about keeping a minimum standard. These match the essential newborn care guidelines. And those we very directly monitored from the essential newborn care. 3 neonatologists, and what you can then measure here, there's a few more things that we did measure, but this is essentially keeping it feasible, practical. and staying focused on the primary outcome. Was that a good answer?
Yes, no, I think that was perfect. You got at what I was hoping you'd get at, that sometimes we need to consider what's feasible when we're thinking about our outcomes. Go ahead, Sarah.
Perfect. Thank you. So let's talk about the statistical analysis now. So the sample size was estimated on the basis of the primary outcome with a two-sided 5% significance level test and a power of 90%. And a total of 4,200 infants accounting for a 10% follow-up were needed to detect a 20% mortality reduction. The primary analysis was performed according to intention to treat principle. So even if kangaroo mother care was discontinued because of clinical conditions of the baby or the infant was not excluded from the study. No imputation of primary outcomes was needed as mortality information was available for all enrolled infants. Baseline characteristics were compared between the two groups, and that included maternal age, the socioeconomic status of the family, the mode of delivery, birth weight, APGAR scores, and age at randomization. And the team summarized continuous variables as means and standard deviations, and the categorical variables as frequencies and percentages. The intervention arm was compared against the control arm for the primary and secondary outcomes using risk ratios with 95% confidence intervals. And for binary outcomes, a logistical model with binomial distribution was used to obtain confidence intervals, and a log-link function was used to obtain relative risks. For continuous outcomes, the intervention arm was compared against the control arm using hazard ratios and 95% confidence intervals. So this is the chart for screening and randomization of all the patients. So around 87,000 women were pre-screened, and out of those, 10,000 approximately were excluded because either the women were discharged or sent to a different hospital or they passed away. And then out of those remaining 77,000 mothers, 72,361 mother-infant pairs was ineligible because they did not meet the birth weight criteria. Either they were less than 1 kilograms or were greater than 1.8 kilograms. And around 2,700 mothers had stillborn infants. Out of those, we had 4,859 mothers. And then they all met the criteria for between 1 to 1.8 kilograms, and then they were assessed for eligibility. And around 1,900 mother-infant pairs was not enrolled because either consent was not obtained, or if the baby had complications, was unable to breathe during the first hour of life, or if they had any congenital malformation. There were around 494 mothers who were not approached within 2 hours after giving birth, which I thought was an interesting finding. And I don't know if it could probably bring in some selection bias in the study. I don't know if Dr. Bergman had something to add for this.
I can add, yeah. So that those 72,000, 87,000, basically every single mother giving birth was screened using a form where the likelihood of a preterm infant being born led to taking consent should the baby be born. So it meant that if the baby was born preterm or low birth weight, then it would be, do you remember giving consent? Yes, let's go ahead. Otherwise, those mothers who 400 mothers provided consent after birth, separate procedure required longer to get ethical consent and explain it properly. So I was amazed that so much effort was prepared to be made to make this as watertight as possible. Now you got 500 mothers that fell through the gaps.
Yes.
And I don't have a good answer for what's inside those 500 mothers. It's the 3 or 4%. So in terms of the selection bias, I don't think it contributes significantly, but it was a very real thing. And we as monitors, when we came there, we would look at these numbers and keep tightening the screws. But this is a real world. This is a busy unit. The India hospital has 100 deliveries a day. Some are going to slip through the cracks.
Yeah, no, definitely. I think you all did a great job at just screening so many women and enrolling so many at each site. So out of the remaining, we had around 2,944 mothers and 3,211 infants who underwent randomization. So there were 1,470 mothers who were assigned to the intervention group and 1,474 mothers who were assigned to the conventional care. And then we had around 1,606 infants who were included in the analysis of the primary outcome that was assessed at 72 hours, and 1,599 infants in the control group. And then for the primary outcome that was assessed at 29 days, we had 1,596 infants in the experimental group and 1,587 infants in the control group. So this is a table which just looks at the baseline characteristics of the infants and mothers and their households. They're pretty much comparable in both groups, the intervention and the control group. The mean gestational age in both groups at birth was around 32.6 weeks, and the mean birth weight was 1.5 kilograms in both groups as well. Then this table shows the initiation and duration of skin-to-skin contact of infants with mothers or the surrogates. So the median time to initiate skin-to-skin contact in the intervention group was 1.3 hours. Was 53.6 hours. The median duration of the NICU stay was 6.4 days in both the groups. And during the NICU stay, the median daily duration of skin-to-skin contact in the intervention group was 16.9 hours, and that in the control group was 1.5 hours. And the main reason that the skin-to-skin contact was interrupted in infants was mostly for medical procedures for the infant and for routine activities for the mother, but otherwise it was not interrupted in the intervention care. And the median daily duration of skin-to-skin contact in the kangaroo mother ward once the babies were transferred there was 20.2 hours in the intervention group and 19 hours in the control group, which was not very different. So this is the table which looks at the primary and the secondary outcomes. So the death between enrollment and 28 days of age, you see there was 12% in the intervention group and 15.7% in the control group. The risk ratio was 0.75, and there was 95% confidence interval was between 0.64 to 0.89, and the p-value was significant at 0.001. And the death between enrollment and 72 hours after birth was 4.6% in the intervention group and 5.8% in the control group. And over here, like Dr. Bergman mentioned earlier, at 72 hours, the p-value was not as significant, but at 28 days, it was definitely quite significant. So results for the secondary outcomes are also shown here. The significant outcomes that were seen was in hypothermia and in suspected sepsis. So in suspected sepsis, it was 22.9% in the intervention group and 27.8% in the control group. And in hypothermia, it was 5.6% in the intervention group and 8.3% in the control group. I found it interesting that suspected sepsis was clinically significant because I think the definition that was defined was mostly like a clinical criteria. If the baby had worsening respiratory distress or had, changes in temperature that would cause, you would suspect sepsis in a baby. But I think it might be prone to some clinical or subject bias as well. But apart from that, the other secondary outcomes were not significant. It's also interesting to see that the time to stabilization and the incidence of hypoglycemia and feeding fully by suckling at the time of discharge and exclusive breastfeeding at the end of the neonatal period was similar in both groups. And then they also did a post hoc analysis, and it showed that in the intervention group, the rates of breastfeeding in the first 24 hours was 58.5% and was 45% in the control group. So this is a subgroup analysis which looks at the different sites. So the intervention had similar effects across the categories of birth weight, gestational age, weight for gestational age, type of delivery, and singleton or twins. And benefits and points were noted at all sites except for Ghana, which I've thought it was an interesting finding as well.
Dr. Carlo, can you chime in here and
This group,
Dr. Carlo, can you chime in here and give us some insight into, in clinical trials, how there can be such big variability between different sites, how you try to control for that? And then Dr. Bergman, would love to hear your thoughts specifically about why there might have been between site variability in this case.
Yes, Mari. So as expected, there will be some variation in every multi-center study that I've seen. There's some center variation, and the important thing is sometimes is if there's an interaction effect by center, and I cannot remember that they did it, but looking at this, I would say there's no interaction by center. So you would say, and the statistics can show that there's not too much heterogeneity in this outcome, even though at first look, it looks like, okay, only supposedly it works in India. But when you do a meta-analysis, these sort of differences do not highlight you cannot conclude that there are differences between center. This happened, for example, in the support trial, that each of the 5 trials had slightly different results. And then when the analysis of the major outcomes is done, there was a minimal heterogeneity in the results. Thank you.
Muted, you know.
Yeah, Dr. Bergman, you want to comment on the variability in the sites you personally experienced?
Yes, thank you. So if you look very carefully at Ghana, at the control mortality, 10.8 is the lowest mortality of all. Yeah? And so here was UK-trained physicians who suddenly got a whole package of equipment, CPAP machines, oxygen concentrators, monitors that they knew how to use. And you can see how beautifully they used them. They were also right next door to an obstetric unit where the first lady of the country had donated some millions to build a fantastic unit with a very, very powerful air conditioning system that couldn't be switched off. And this was all new and upheaval, and the obstetric and the neonatal collaboration wasn't that 100%. And the PI was actually a public health man at another university. So Ghana actually only started skin to skin at about 4 hours. And they only managed to do 10 hours a day. They were very upset about this. And we worked very hard with them. If this study had continued to the 4,000 level, that was the target, they would have turned the corner because it took a long time for them to come straight. 2 hospitals came straight in weeks. 2 hospitals came straight in months. Ghana came straight in a year and more. But it's very nice result, actually. It shows that if you do 1 hour, which is the average of all the other sites, and if you do 20 hours a day, which is all the average of the other sites, you will lower mortality. starting 4 hours is too late. Doing 10 hours a day is too little. So that's actually quite nice. We haven't got to unpacking this, but I have this data. So I can tell you something more. India, their mortality in the intervention group is 10, and 15 in the control group. But they've got 100 births a day. They've got an intensive care unit that's severely overcrowded. And they follow this principle more than the other sites, sending babies home at 1,400 grams. This profoundly affects their mortality because there is a post-discharge mortality. So if you take away the post-discharge mortality in India, they would be doing almost as good as Alabama, I should think. Yeah.
That's a really good
Don't want-
point you raised, Dr. Bergman.
Don't want to be offensive to anybody anywhere else, or to India or Ghana, because here we're highly skilled physicians doing amazing work. So there is, Wally, you said this is a low-cost intervention. Actually, I want to make a bit provocative interjection here and say it's not an intervention at all. The interventions given to these controls and the groups were identical. The breastfeeding support was identical. My wife taught it identically to controls and others. So 29-day exclusive breastfeeding rate is 85% and 86%. So it's only skin-to-skin contact, which is different. And it's not an intervention. It's a different place of care. I'm saying this very slowly, Matti. Sarah, I can't see your face. It's not an intervention. Yeah. It's a place in which interventions are provided. And the interventions are provided according to the package of care of the WHO, ENCC, monitored carefully by 3 Scandinavian neonatologists, that it was followed in both groups the same, without differential, that it was maintained across the 5 sites at the same intensity and quality throughout. We visited every 4 months. The WHO separately visited on the technical side. So we had intense supervision with these things. But to come back to my point, it's the skin-to-skin contact, which is immediate. It's the skin-to-skin contact, which is continuous. Mm-hmm. We've controlled for breastfeeding by ensuring that the control group got the same support. Exactly. We controlled for all your other outcomes, Sarah, by making sure that the early neonatal care essential package of care was followed in both groups. So there was some disappointment that there was no differences in the outcomes. But no, we worked hard to control for them. We made sure that the care given was the same to both groups, that the breastfeeding support was the same to both groups. This is fudged in the way the article is written, says me now. It's nearly 6 o'clock, Sarah, so I want to make this point.
Yeah,
well,
definitely.
Thank you so much for insight, Dr. Bergman.
Skin contact, which is immediate. It's skin-to-skin contact, which is continuous. And it is only skin-to-skin contact that decreased the mortality.
Yes, that is true. Thank you for that. It was really a good insight. Okay, so moving on. So this chart shows hours of skin-to-skin contact per day in the first 72 hours in both groups. And as you can see that the risk of death was lower in infants who received more hours of skin-to-skin contact per day, and was higher in those who received less than 10 hours of skin-to-skin contact per day, as it's shown. So in the babies who received less than 10 hours, you could see it was 31.3%, and then more than 20 hours, it was 3.3% in the intervention group. And then in the other group, you could see that it was also higher in babies who received less skin-to-skin contact per day in the first 72 hours of life. So this shows, this is a table in which all the deaths that happened, the cause of death were listed down, and most deaths were caused by either sepsis or by preterm birth complications. So sepsis associated mortality was 4.4% in the intervention group, and it was 6.9% in the control group. And this was significant. As you can see, the confidence interval was between 0.48 to 0.86. So there was also a data and safety monitoring team that was specifically designed, which was responsible for safeguarding the interests of all the participants and the investigators. And it assessed the safety of the trial's intervention, and it monitored the trial's overall quality and made recommendations concerning the continuation or the termination of the study. So this data and safety monitoring board conducted 2 interim analyses at 50% enrollment and at 75% enrollment. And after the second interim analysis, the Data and Safety Monitoring Board recommended stopping the enrollment in the trial because there was a clear benefit that in babies who received immediate kangaroo care or skin-to-skin right after delivery had more benefit and had reduced rates of mortality. So definitely based on this study, the findings for the primary outcome and also for infection and hypothermia were similar to those that were reported in earlier trials of kangaroo care in infants. And that shows, that goes to showing the importance of skin-to-skin contact immediately after birth. And the study was pretty strong in terms of the number of participants enrolled in the study and how multi-centered it was. And the results were definitely generalizable to most hospitals in low or middle income countries where immediate kangaroo care can be implemented. So the reason why kangaroo care is helpful is because with close maternal contact, the baby is more likely to be colonized by the mother's protective microbiome. They're more likely to receive early breastfeeding, which again protects them. And there's also less handling of the baby by other staff and other people. So that could also reduce the risk of infections. I'm sure that Dr. Bergman and the entire team had a lot of challenges, especially involvement of all the stakeholders, establishing these mother NICUs. And there's also like a strong need of collaboration between the OB and the NICU and some changes in policies as well. So I'm sure it wasn't an easy task, but I think that they managed to do a great job. So again, some limitations. The nature of intervention obviously made blinding impossible. And we talked about the 10% or 500 mothers who were not approached earlier. I think there was some data that was missing regarding the use of antenatal steroids or magnesium sulfate, which has shown to improve perinatal outcomes. I think with that data, we would have probably been able to get some more information. And some data was missing regarding when the babies regained birth weight, incidence of IVH or chronic lung disease could again, it's something that would have given us more information regarding the safety of the intervention. But overall, I think that this article or the study was really strong and has been one of the biggest randomized controlled trials on kangaroo mother care.
So Wally, a question for you. Coming to external validity, this has clearly shown an improvement, as Dr. Bergman pointed out, the location where the baby is taken care of on the skin improves the outcome. So how do we apply a study done in the lower middle income countries to the US settings, and the average gestational age being around 32 weeks and 1.5 kg, can we extrapolate those findings to our babies, or do we need any further evidence from high income countries given the different support?
I think given that this study shows very important benefits and safety in a small population immediately after birth, within the first 2 hours, I think this provides some reassurance to clinicians that this is also an effective treatment. So it's not, that is a safe treatment, not just effective. It is effective in developing in low resource settings in terms of mortality, but it's also found to be safe. And I think this is an important message that we can learn from this and apply this to high income settings. In addition, we had acceptance from the mothers, acceptance from the staff. So there's a lot of lessons that can be learned for immediate skin-to-skin contact, rather than contact that is restricted so much in many high-income countries. So I think that's a lesson that we can learn from this. Thank you.
Wally, do you have any recommendation of gestational age? This was 32 weeks. So when trainees go back, what can they advocate for immediate skin-to-skin in their unit?
Yeah, I think also, in addition to this trial, there's a lot of evidence, some of it from higher income settings, that show also some other outcome measures that were improved, not just mortality. Besides mortality, other outcome measures that are quite important also. So if you look at the meta-analysis, it's pretty consistent with the multiple benefits of great importance. For example, I like to highlight breastfeeding. Breastfeeding rates in the US are very low, lower than in most lower resource settings or lower middle resource settings, lower than in Europe in general. So I think that's something that is extremely important. The meta-analysis also show improved breastfeeding rates. So there are other benefits. And then finally, a final point is that WHO has a package of care called Essential Newborn Care, and there are many other groups that have like essential care for every baby, the American Academy of Pediatrics. There's many packages like this. But the message is that KMC is an essential component that packages of care. For example, it helps with breastfeeding. It improves also thermoregulation. Some aspects that are essential or part of the essential newborn care programs. So I think there are benefits that can be extrapolated to higher resource settings like the US.
We'll get to the questions in the end. Sarah, you want to finish up with your last few slides and we can move
Yes.
forward with final discussions?
Yes. So in conclusion, so kangaroo care definitely improves outcomes for low birth weight infants, and earlier and longer it's implemented, the higher the benefits. So obviously we need future studies to evaluate implementation difficulties in certain settings, like we mentioned. How could we in higher income countries or in developed countries, how could we coordinate that? Feasibility is definitely a question when babies are likely to require respiratory support and intensive care. There was a qualitative study that was done in 11 NICUs in Canada, and they identified barriers like the physical environment of the NICU, especially if you have like an open bay unit and not like separate rooms, or healthcare provider beliefs, or just like the presence of the parent, and the entire clinical practice variation. So these were the barriers that they identified. But definitely in well-resourced settings, if we conduct, or if not mortality, then other benefits like breastfeeding, etc., are things that could definitely be enhanced in our neonates. And that's just something that I think is a great intervention, which could be incorporated in our NICUs. And that's about it. These are my references. And thank you so much, everyone, for listening. I'm happy to answer any questions.
So, Dr. Bergman, a question for you. So it's a great trial, clearly showing the benefits. How do we overcome the barriers which Sarah pointed out in the developing countries, like providers' beliefs, parental beliefs, and things like that? So it's just education, or can we as trainees do something to improve these?
I'm slightly missing your point and your
So
difficulties.
how do we address the barriers of the physician's belief? They do not believe that, a baby should do KMC. I mean, is there any insight we can do to make this a routine in developing countries?
So I have grappled with this very question for 30 years. So if I have difficulties, I don't have an immediate answer. But I can make a couple of comments to everybody who's listening and your trainees and you're going to be doing research. I really, really strongly feel that a high-income country randomized controlled trial on this is really needed. This wasn't actually immediate. This was early. 1 hour, we already defined in another Cochrane review on skin-to-skin contact for healthy term babies, Moore, myself, Anderson, Medley, and 10 minutes is immediate. 1 hour is very early. More than an hour is early, between a day. So actually, this is not an immediate skin-to-skin study. The two trials that I was first author of and last author of, they were actually zero separation. Zero separation is the term that now WHO regions are adopting. And so skin-to-skin contact in the scientific rationale is the place. And we controlled for everything else. And if you do this on primates, this is called a separation study. And separation comes with toxic stress. So what would I say to all of you trainees? Actually, we've got our normal value wrong. We think it's normal to be in an incubator. And now we're doing something very, very dangerous, putting the baby in skin to skin. Actually, it's very, very dangerous for the baby to be in an incubator. If I had said 12% mortality in this group, and now I put normal 12% mortality into an incubator and I get 16% mortality, I increase mortality by a third by putting a baby in an incubator. I'm wanting to be provocative. Please, nobody has done the immediate skin-to-skin trial. Yes, there are some small studies that have shown it. Can I make a second point? This comes straight from the talk and it comes from the WHO. For example, can a surrogate provide KMC? KMC is skin-to-skin contact, support for breastfeeding, early discharge, getting the package of care. A surrogate doesn't do KMC. Please, please, please. Sarah, what does a surrogate do?
Just do skin to skin, maybe.
Can I ask you all, please, to be particular with your terminology and to be scientific? We need to speak about skin-to-skin contact. We can start it immediately or early or late. And once we've started it, we can do it continuously. And that is the current recommendation of the WHO. Start it immediately and do it continuously. Now, we haven't actually said, is separation actually a default toxic stress in the whole environment of early childhood development? So toxic stress separation, I would appeal that please use the terminology skin-to-skin contact. That's what it is. And then we really need, and I would be happy to help anybody, Wally, we can start. This needs to be done in the United States. The opportunity is that we can actually do it much, much better than Sweden failed to do immediate, than the WHO that only started at 1 hour. We've got a backlog of transition to extrauterine life with high levels of toxic stress, which is cortisone, DHEA, a whole lot of stress hormones, signaling hormones, which have to then still apply recovery. So there's a scientific rationale that I also have published on this, and that's not the time to bring this in. But the opportunity really is that skin-to-skin contact is a place. it's separation that babies don't tolerate. How would you measure that?
And as you pointed out, maybe stress hormones.
We already know that babies in incubators have cortisol levels that are 10 times what is toxic to a rabbit brain.
Very interesting. Yeah. Wally, you had some comments?
Yes, so Viral, so the point of early or immediate is extremely important. And by the way, most of the guidelines recommend immediate care for babies in general. So, for example, helping babies breathe, that's immediate holding the baby. In fact, I see Dr. Susan Niermeyer here. She was the instructor for the study that was done with 200,000 patients that we did in Africa, Asia, and Central America, South America. And it was immediate KMC on those babies. And even resuscitation was done on the mother's chest. So that study that 200,000 patients and show a reduction in mortality. That's a very important intervention early after birth.
Yeah, that's a very good point. And with all the studies showing the benefits of delayed cord clamping too, maybe things we were doing in a hurry is probably, and separating the mom and dad is probably not a good idea. And it's time for US to change how we practice too. I'm going to take some audience questions quickly before we wrap this up. Dr. Bergman, you have a question, comment?
Comment to just follow on, Wally, and yourself. Delayed cord clamping means that you've got 5 minutes when you didn't separate your baby.
Yeah.
So this is part of the package of care. The other piece, which immediate kangaroo mother care study got, was early expression of colostrum. And the babies were given it. And 2-hourly expression thereafter. So there's a kind of life history package really centered around the reproductive physiology of oxytocin that applies in the first hour and that can be easily disrupted. So yes, you're quite, please stay with delayed cord clamping, but add colostrum to this package. Early colostrum.
Yeah, very good. Question from the audience is, it's a pretty good question. There is often a perceived conflict between skin to skin and safe sleep, which causes resistance in adoption in the US. How can we overcome this? Wally, you want to comment on this?
Yes. So I'll just say that there's evidence of better respiratory stability with KMC, measuring different ways, but more stability with respiratory control. Dr. Bancalari is here today also, so he may want to comment. But the meta-analysis show benefits in respiratory control during KMC. Over.
Okay, and another question, Dr. Bergman, for you. Given the differences in hypothermia, differences on hypothermia, would like to learn more about what was the standard of care for temperature control on the control groups who did not get the immediate KMC.
One site I already identified had issues. The other sites had long addressed the temperature issues. So we didn't flag ourselves when we walked around and how it was that the sites themselves. So warm blankets, keeping things dry, the warm chain is part of the essential newborn care packages that Wally was referring to, fundamental part. So I think even under the best of circumstances, for example, in Norway and Sweden, where you have state-of-the-art care, we showed less variability of temperature in skin to skin than in incubators, and less hyperthermia in skin to skin.
Interesting.
So it's the place that regulates the baby.
Thank you. That's all the questions we have. Thank you so much for such a wonderful insight. It looks like a simple study, but there's a strong science behind it, and the benefits are humongous in terms of reducing mortality. Very few intervention with such a low cost show such a large effect for it. And I'm very grateful that we have you, Dr. Bergman, and Dr. Carlo for this session. Any final closing comments, Dr. Bergman, for our trainees in the audience?
Thank you very much for including me here. And if anybody does want to do the study, please get hold of me. But otherwise, I have published the scientific rationale for this that you can Google or find in PubMed.
Yeah. Wally, do you have any closing comments for our trainees in the audience?
Just embrace this. We actually had an expert from Europe that came to our unit about 30 years ago and did the first course of essential care in a high-income country, essential newborn care in a high-income country. And we found so many benefits, including immediate contact. So we started that about 30 years ago, and it was a requirement, especially of sick babies. So I think it's possible to do. I think embrace it and do the research. I think Dr. Niermeyer mentioned the important things, for example, respiratory stability. Yeah, those studies have been done in high-income countries, and studies like that are necessary for our settings. So thank you very much. I think it's a great idea, a great study. Sarah, you did a fantastic, Niels, fantastic to see you again and work with you.
Thank
Yeah,
you very much.
excellent presentation, Sarah. Very well summarized. We have a next session on the Eat Sleep Console trial with Dr. Leslie and Dr. Poindexter on April 4th, 3 p.m. Eastern Time. We hope to see you all again. And please don't forget to fill the survey which comes up to help us improve the sessions. Thank you all for coming. We'll see you again next month soon. Thank you so much, Dr. Carl, Dr. Bergman, and thank you, Sarah.
Thank you for the opportunity. Thank you.